Hope you enjoyed the breakout sessions. There seemed like a lot of good energy going on out there. So just to wrap up our forum today, again, we're very delighted to have our last but least not speaker, Dr. Connie Lehmann. She's a professor of radiology across town at Mass General and Harvard, and we have been talking about lots of great research ideas that we can do together. And one of the things that she's been working on that I think we'll all be very interested in is, again, using artificial intelligence to try to predict cancer risk. So, Connie, thank you for joining us.
Thanks so much for having me, and thanks for coming back after those really cool sessions and before lunch, because I'm sure it'd be like, oh, AI, really? I'll hear about it later from my friends. So I really want to keep this relevant. AI in medicine can seem a little bit scary to a lot of people, or not really relevant, or about as far away from a patient care experience as you could imagine. So when my friends heard that I was going into radiology, they was like, that is so not you. You're going to hate it. You're such a people person. But it has been an exciting career for me because, especially in the domain of breast cancer, we have such an opportunity to have a significant impact on individual lives and large populations of women and their lives. So what we're really intent on doing is how can we leverage the tools of AI to improve patient care experiences and to improve patient outcomes. You'll hear lots of people in AI that you sort of get the feeling that they're building a bunch of hammers and they're going to figure out where the nails are later. We're really starting with what are our most pressing problems. It was a very personal story for me and my partner, Regina Barzilay, who is an expert in artificial intelligence at MIT. At the young age of 42, she was told, we found something on your mammogram. And every woman that's ever heard that is convinced that they have breast cancer, even though most women who are called back from a screening mammogram do not have breast cancer, but in Regina's case, she did. So she went through fairly aggressive treatment. She had an aggressive cancer. Chemotherapy. This photo shows Regina with her young son, and she decided to shift her entire lab of artificial intelligence at MIT over to cancer, but she needed partners to do that. So she talked to a radiation oncologist and said, can you introduce me to people? When people later asked Regina, how did you end up with Connie? Regina's like, she was the only one that would talk with me. So at that point, that's sort of the story of my career, is like, no one else would do it. So, but it's been so exciting. And the first thing Regina and I did was we sat down and we looked over her mammograms together. And she said, I started screening when I was 40. So in 2012, I got a letter and it said, you have dense breast tissue. And your mammogram is fine, we'll see you next year. So she called her doctor and she's like, what does this mean? And they said, don't worry about it. About half of women are told they have dense breast tissue. We wouldn't recommend anything different, you're fine. The same thing happened in 2013. Then 2014, they said, oh, we see something. So as she and I were looking at the mammograms, the question is one that comes up to all of us in mammography. Could this have been seen the year before? Now, we can go back and say, oh, we see something there, but is that thing we see, is it different than all those other white splotches all over the mammogram? So would we just be calling back every woman saying, well, we can't rule out cancer here, here, here. But we still wondered if with the power of really smart, fast computers, could we analyze these changes over time differently? And also, could we think about this concept of, we're telling you your breast density, this sort of increases your risk, but not a lot, and most women have, half of women have dense breast tissue. Could we do better with artificial intelligence? We wanted to make sure that the tools that we were developing would spread around the world. We didn't want AI to be yet another example in healthcare where new technology divides rather than unites the full diversity of patients whom we serve. So with my background I was so glad that you shared your story. And in fact, I threw this slide in. I was like, yay, she's going global. I love that. So during my career, I was basically trying to boil the ocean. I'd travel around the world teaching people how to read mammograms, how to interpret ultrasounds. We used a lot of fantastic care providers that weren't radiologists. They were internists, they were nurse practitioners, because we just don't have enough specially trained radiologists in the world to read mammograms. But then the question was, if computers could read mammograms, could the impact and the power of screening mammography to reduce breast cancer deaths be realized? We've done that with hematology. We don't have hematologists counting red blood cells under a microscope. We've done that with pap smears. We don't need cytopathologists highly specialized to look at these cells under a microscope. Are we ready to do it in mammography? I think that we are. We also wondered, so that would be an area where we're taking smart computers to do something that humans are doing, looking at mammograms to find cancer. There's another domain is what if you could take computers to do things that humans actually can't do? So humans can see density, but they can't look at mammograms and say 25% lifetime risk, 10% lifetime risk, but could computers do that? Could they extract more data out of the mammogram than just something as crude as dense, not dense? And in fact, in the same ways that our risk models are very limited now, because most risk models have been developed on European Caucasian women. They don't work very well in African American and Asian and Hispanic women. Could we do more with AI, taking big data and predicting the future better? Every mammogram, like the face of every woman, gives us information. There are these hidden treasures in the mammogram that we can't pull out with our human eyes. But we think that really smart computers are able to do that. The field is radiomics. We hear about genomics or proteomics, but there's information within the images, and before AI, I just don't think we could pull that out, whether it's a mammogram or an ultrasound or an MRI. So every woman's mammogram is unique to her. If the technologist comes in and shows me a new case, and then somehow in our PAC system it got twisted around, so someone else's mammogram is there as the comparator, I'll know that because the mammograms don't look the same. It'd just be like if you put a woman's face up and then another woman's face, it'd be like those are two different women. So we wanted to leverage that, and all of that digital data that we now around the world have been collecting for decades is there for the taking. A lot of work to curate and annotate and have high quality data and images to do this AI work, but no better place than the Boston community and partners to do that. So I'm going to hit 3 areas that we worked on with our AI just to give you real world examples of what we've been doing. The first thing we thought we'd tackle is what about breast density? So this federal legislation was an example of absolute best of intentions to inform women of an important piece of their health. What is your density on your mammogram? But are we informing women or are we misinforming? And the reason why I was concerned is even though it seems straightforward, this woman has fatty breast tissue, this is scattered, this is heterogeneously dense, this is extremely dense, it seems straightforward. We studied 85 radiologists out in community practice. They had read lots and lots of mammograms. And then we looked at, well, how does it end up falling? How do they assess mammograms? Well, at one end, a radiologist said, I think 6% of mammograms are dense. And at the other end, there was a radiologist that said, I think 85% are dense. And we actually, it wasn't just what they thought, it's how they assess mammograms. So you could go to a radiologist that's telling almost everyone they have dense breast tissue, or you could go to a radiologist that's saying, I don't think anyone has dense breast tissue. We also have found in research that if you're in a state that mandates density reporting, your assessment goes up. And if you're in a state that also requires insurers to pay for supplemental imaging, your density goes up even higher. In the states that have mandated that insurers need to pay for supplemental imaging, radiologists on average are assessing up to 60% of women as dense, compared to states that have neither the density legislation nor the insurance payments for supplemental imaging. They're under 40%. This is a huge difference in finances in informing or misinforming women. And there are harms associated with supplemental imaging, particularly in patient populations where it's not indicated. So what are we doing in AI? Well, I was first a little bit discouraged because I was like, oh, we're so far behind. They're doing all this cool AI stuff in cars and the military and Google, how we shop, all that, and we're so far behind in healthcare, but we can take a lot of the tools, especially in image analysis, whether it's the cool AI work being done to look at the internet, is this a legal or an illegal weapon that's being sold on the internet, the military's looking at different map areas, is there been activity, yes or no, is there change over time? A lot of that AI technology we can translate over into imaging, whether imaging of skin lesions, the back of your retina, pathology slides, or in my domain, radiology images. So in a simple neural network process, you give the model a whole lot of images of cats and dogs, and you tell it what the outcome is, and it learns really well over time, even as things are all mixed around and stuff. Is it a cat or a dog? And that's all we're doing in mammography. We have this huge collection of images, and we know what the outcomes are. And we can train the model for all different kinds of outcomes. We could say, here's all the mammograms in a woman that developed breast cancer in 5 years, and these are all the mammograms in women that did not develop breast cancer in 5 years. These are mammograms in women that highly expert breast imagers assessed as dense. Here's mammograms that were assessed as not dense. Here's a woman that had breast cancer within that year, so we should be able to see it on the mammogram now. Here's the ones that did not have breast cancer in that year. So we got started, and with the breast density, we had 97% agreement with expert readers, and we found that when we implemented this both in our own academic practice as well as friends and colleagues in the community, it reduced what we referred to as the over-assessment of density. So in Massachusetts, we had a certain level of density reporting. After the state legislation, density went up. Obviously, the state legislation didn't create more dense-breasted women in the state, so this was more about subjectivity of the assessments. And then once we implemented our AI, it came back down. So we do think that this is a more consistent, more accurate method. But then we said, well, it's so limited to tell someone their breast density. What if we could pull more out? Not just what's your density, but actually what's your risk. So we did exactly the same thing, but then the outcome we trained the model to predict was future risk. We thought there was an opportunity here because even our most robust risk models in looking at risk in average risk populations, they aren't great. One of the metrics we use is something called area under the curve. If you had an AUC of 1, you'd be perfect. You'd get it right every time. If you had an AUC of 0.5, it's half the time you're right, half the time you're wrong. It's flipping a coin. So you want to be as close to 1 as possible. The AUC, for example, of the Breast Cancer Surveillance Consortium risk model, which is widely used, is 0.63 if you include the mammographic breast density. Without that mammographic breast density, in most studies, it's around 0.661. So what we did was we did exactly the same thing we had done for density, but now we're going to predict future, at least 5-year out risk. Yes or no, did this woman with this mammogram develop breast cancer? So what we found was that first we took traditional models and projecting. So some of the better risk models out there, one's called Tyrer-Cuzick. There are many versions. The most recent version, which also includes the mammographic breast density, is Tyrer-Cuzick version 8. So we tested in this big population we had Tyrer-Cuzick version 8 and found the AUC was 0.62, which sort of fit with what other publications had said. And our model was 0.71. But then we looked at the subgroups and the subpopulations, and we were really surprised to find out that in any subgroup that hadn't been used in developing the Tyrer-Cuzick model, the Tyrer-Cuzick model significantly underperformed. The most striking was in women in our population that were African American. It was worse than chance of 0.45. We also saw extremely poor performance in Hispanic women, in Asian women, in postmenopausal women. Most of the Tyrer-Cuzick version was in young premenopausal women, in women with a family history. There was a very select group that the model was developed on, and that didn't translate. For whatever reason, in our model, which has the image of each individual woman predicting, it was picking up cues in that image that we think is more robust than the traditional factors. How many family members with breast cancer? When was your first pregnancy? How many children did you have? Did you nurse? So we were really excited about that. We did add on to our image the traditional risk factors, but found while it bumped it up a little bit, not very much. And we're continuing to build. The more data we have, the better the model gets, and its accuracy and precision has continued to go up, and we have not seen a dilution of that consistency across the subpopulations of women. So we're very, very excited about expanding on this, and we're working with many different groups for what we refer to as wide external validation. We've validated in different populations besides just our own, but we want to have this in other countries in more diverse populations than we would have just in the Boston area alone. So that was looking at how AI could be used to leverage information in every woman's individual unique mammogram to predict the future. We had sort of gotten hints about this because if I sit down with a resident to read mammograms, there's a story there on the mammogram. It's, well, this is about her density, but we can also see, has she gained weight? Has she lost weight? Is she on hormones? Is she not on hormones? Is she on chemoprevention? There are changes after tamoxifen, for example. Dietary changes can influence the mammogram. Are there certain kinds of clips that mean she's had a prior needle biopsy, other kinds of clips that suggest an excisional biopsy, and yet other changes that show us that she's been treated for breast cancer? And so all of these clues can be extracted, and we haven't been doing that until now with the power of deep learning and machine learning and these tools that we can use. So then the last example of how we can use AI I wanted to touch on is that basic question, can computers read mammograms better than humans? When people ask me, what's the sensitivity and specificity of mammography? How good is it? And what about if you move from old school analog film screen to digital to modern 3D tomosynthesis? And my answer is always the same. It depends on who's reading it. There is no performance of a technology. It's in the hands of the human. And that's been one of our biggest challenges in radiology, is we have pushed in such exciting ways into new areas of new technology, from analog to digital to tomosynthesis, from old school MRI to modern fast MRI, which shows us better and better early cancers and their behavior. But what we haven't been as good as doing, despite an unbelievable amount of continuing medical education, training, requirements by the government for what you have to do and the auditing you have to do, we're more regulated in breast imaging than any other area in radiology by far. Despite all of that, we still have human variation. So this graph, for example, shows performance in a very large study of radiologists in the country. Sensitivity of mammography, it depends on who you are. You might find 25% of cancers, or you might find 95% of cancers. The average is about 85%, but that doesn't mean anything. It's where you go and who's reading it. The same with specificity. The error bars are a little bit tighter, but you could go to a center where the recall is 5%. You could go to a radiologist that recalls literally 35%. So 1 in 3 women getting a screening mammogram is told, we see something, we need to do more tests. So the human variation alone is my answer when people say to me, why are you running us all out of business? Why are you going to replace radiologists? It's like, hopefully we're going to enhance them, but there is a need. And when people say we're doing fine without these tools, I just show them these graphs and lots of other studies we've done showing the wide human variation. So, and then I also point out, you know, as the technology keeps improving, we've far surpassed human ability to interpret all that data. We have much too much data, and that's in every domain in healthcare. You look at everything we can spit out now on the human genome, genomics, proteomics, blood tests, imaging, pathology, and we're just scraping the surface of the information that we actually put into models. I mean, I look at some of these models that we have, and they have like 8 factors in them or 9 factors in them. We need AI to be able to take all of this data and really change our thinking about how we predict the future. So in a regular screening mammogram of an average-sized breast woman, I have more than 200,000 images to look at. Sorry, if I look at, I've got more than 200 images to look at. So I'm now going to say I'm going to screen 1,000 women to find 5 or 6 cancers. I've got to look at 200,000 images. And that is an impossible human task. And I want a computer to help me with that. So we've done that. And what we are now doing is using it to triage. So can we take mammograms that the computer has said, this is so incredibly unlikely to have a cancer. This can be over here. We're still reading all of them, but it's a different style and a different way of reading. And the more data we bring in, the better the model comes. I don't know if you've seen any of those examples of like AI and chess or Go or the different games, but it is exponential. The more data, the more precise, and that's what we can do in this field. So My biggest hope is that we can continue to have these types of forums where people can hear more, patients can hear more, advocates can hear more, so that we can think more about how can we, with a curious mind, think about how can we use this to help the full diversity of patients that we serve. It can be a little scary, you know, like some of the people in radiology that are scared are like, I wouldn't want a computer to read my mammogram. And it's like, okay, well, sometimes I'm really nervous about the humans out there reading mammograms, but that's okay, you know, and we all have our fears. But at the end of the day, we still are faced with, we have more than 3 billion women that could develop breast cancer. 2 million will be diagnosed. How do we find those 2 million early so that we avoid the 600,000 that every year continue to succumb from this disease that when detected early, or even better, when prevented, we can avoid the impact on patients and their families. So thanks so much, and I really appreciate the invitation.
So, thank you very much, Connie. Maybe time for 1 or 2 questions. I know we didn't give you all much time to ask questions earlier today. So,
I just had a question about the last slide. Is it 3 billion women in the world, or 3 billion that get mammograms?
It's definitely not that get mammograms. So that was sort of my crude attempt to say, we know from most of the big databases out there that roughly 600,000 continue to die every year, and about 2 million are diagnosed. So if we look at, like, you know, the world population is 7 to 8 billion, a little bit more than half are women, and so that's sort of a rough estimate of a reasonable projection of the numbers that we would have of women that we would be thinking, can this woman get breast cancer? It's in a few billion, meaning that we're trying to avoid interventions in the billions of women that will never have breast cancer and yet might have a significant part of their life impacted by fear of breast cancer, tests, surgeries, you know, other things.